Hey guys, I'm gonna take you through a day in a life of a nurse practitioner in nursing care. So you come in over here. I just come into work right now. There's the waiting room. Here is the receptionist's office. Here's some coffee for people. So what typically happens is that the patient comes in, they're seated over here, they sign in over here. Then the patient will be taken through the hallway. They'll get placed in a room. Over here on the way, if we need a urine sample, there's a bathroom right here that may give them a urine cup if they're here for specific complaints, and then taken into a room. So let's just go into this room. So then they will bring the patient here, sit them right over here, and take the vitals. So you have your blood pressure cuff, you have your temperature, you have your pulse ox in there, etc. And then after that, they take their vitals, then they will log them in. So over here, the patient will come up, and I'm just gonna take a template just to show you this is not a real patient. This is just to show you, let's say someone comes in with an ankle sprain. So this is a template, this is not a real patient. As you see over here, it says template, there's a made up date of birth, made up everything, made up street, and it's just saying that I'm the provider over there. So here's a chief complaint. This will be written usually by the MAs or the patient, why they come in. Belly pain, very simple, you know, in the patient's words, whatever they say. They're here for upset stomach, whatever they're here for. And here's the HPI. This is usually written first by the MA and then fixed up by the provider, or written by the provider. Everyone does it differently. The MAs usually write it. I like to write my own, but that's, you know, my own preference. And then the MAs will go through all this. They'll ask the patients their medication, medical history, allergies, etc., history, you know, if they're hospitalized, family history, and social history. And then they'll leave the review systems blank for me. They'll put in the vitals, like they got the weight, the height. Usually the weight, the height, they'll just ask because, you know, they're not here for physicals. Unless they're here for a physical, then they'll put in the weight and the height. Otherwise, they're just here for like stomach pain. They'll just ask them the weight and their height. But all the other vitals to put in. Then the examination they'll leave blank. That's for me. The assessment and treatment they'll leave blank. So then right before they leave the room, they'll put one of these up. So I'm just making up the thing, but let's say white is for ready for provider, and then when I come, let's just say gray is that provider's in there. And then when I'm done, I put them all up so that they know to clean the room. So that's just like a system, you know? So let's leave the white for now, ready for provider. So then over here is the provider's room. They'll come in. So I'll be sitting here and they'll say, oh, you have a patient in room 5 here for ear pain. Now, a lot of times they don't tell the MAs everything they're here for. So let's just say they're here for ear pain and whatever. They won't say the MAs everything, they won't tell them everything, or they'll leave out a lot of detail. So I like to get my own HPI, my own questions and everything else like that. So sometimes I'll log into the computer right here and I'll just check up if they were here before for that same incident. You know, you could check up by encounters and see if they were here before, see what they were treated with last time, if they're here for an allergy or something like that and stuff like that, just their basic medical history. I also like to look up their vitals before I go in because the vitals make a little difference in terms of, you know, if you're gonna stable discharge them home or not. So I always look up their vitals before I go in. I always just like to look up encounters to see if they're a new patient or we have some history on why they were here before. And also you also have to know that for billing purposes, if they were a new patient or not. So I look up that and then I go into the room. I always have my stethoscope in there and everything else is in the room. Usually I'm wearing a mask. I don't have a patient now, so I don't have to. So I come in, the room is usually closed and that's up. So I knock on the door. I introduce myself, I say, hi, my name is Sarah, I'm a nurse practitioner, you know, what are you here for today, or however. Then I sit right over here, and the patient's over here, and then they'll tell me their history. They'll say, oh, I'm here, whatever, and I'll ask like the whole HPI out loud. You know, the onset, O, P, Q, R, S, T, that, all that, what provokes it, what makes it worse, what makes it better, anyone sick around you. I go through the whole entire thing. And then I'll chart that in the HPI section over here. So because it's an urgent care and they're here for one thing, it's a focus assessment. I always listen to the lungs and the heart, etc., and all that, and the abdomen, but I do a focus assessment. So if they're here for an ankle sprain, you know, I'm not looking in their ears. And I don't chart that I'm looking in their ears because I'm not. And, you know, you focus assessment. And after that, Sometimes I'll need to come back in. Let's say I'll be like, oh, they need a pelvic exam, so now I'll give them something to get dressed in, and the MA will come in and set up the whole equipment, and then I'll go out, and then I'll be called back in. And sometimes I won't. Now, in the urgent cares, you'll see a lot of patients. So what I do personally, I'll do the HPI always, and I will do my examination, and I'll make an assessment, and I'll write treatment. I'll write, for instance, this, and then whatever I'll tell the patient. So I'm sitting there with the patient, I'll be like, oh, your X-ray was negative, do an ACE bandage. I'm just making this up. Rice, naproxen, ibuprofen for pain or inflammation, etc. And then I'll always tell them proper precautions, and then I'll leave the room. So now, in that case, because I'll have like 6 other patients waiting in the waiting room, I can't sit there and finish my chart unless I have time. In that case, I could just go back and everything's already done. I don't have to remember, how this patient presented and everything. Everything's done in terms of the HPIs there, my examinations there, and my treatments there. So everything else is just really the review of systems, and everything else could kind of be brought in a template. You see over here? So let's say I'll just bring in this template, and if they complain of fever, I'll just switch it from denies to complaints. And I'll see what their complaints are and their symptoms from the HPI. So then I'll go and I'll log out because you don't want anyone to switch your work. Ask the patient if they have any questions, and then if they don't, then they're good to go. I always remember to give them proper precautions. So follow back up, this, signs and symptoms to watch out for, and when to go to the ER and when not to, depending on what they come in for. So that's pretty much in life. A lot of times I'll have 6 other patients waiting in rooms, and the waiting room will be packed. And some locations that I go to, in different urgent cares that we have, there will be like very little patients, and I'll have time to finish all my charts and everything else like that. So it really depends on the location that you're in and how busy they are, and also different seasons, like everyone gets sick in the winter, they all come in, etc. So it's pretty much what you do. So like I said, when the patients sign up on the front, they're brought back in the back by the MAs. The vitals are taken. Usually they get a history, and they'll verify their medication, medical history, family history, etc. And they'll come in, they'll call you, and they'll let you know what they're here for. You could check their vitals, check everything up before you go in, and then walk into the room. And then when you walk into the room, you introduce yourself always to your patients, and you ask them why they're here, and then you get a full history, you get your H&B, and you do your physical assessment. And then depending on what you see, you do further testing, or you send medications, depends on what they're here for, what you see. And it's pretty hard in urgent cares because the patients just keep coming in. It's not like it's a primary care where you have appointments like once here at 8, and if you go a little over, then the next one, some people come late. These are not appointments. So you could have like no one for a half hour and then have like 20 people come in at the same time. And the whole point of urgent care is that they don't want to wait. So they're here, they want to be seen, and they want to go. And a lot of times it's hard because you'll have ups and downs. So you'll have one day with not a lot of patients, and the next day tons of patients. Also, they'll come in for a bunch of stuff. So you'll have pediatrics, you'll have elder. In terms of what you see, so I would say a lot of it is viruses, like just viruses, cold, sneezing, just viral symptoms. A lot of it is rashes, all different type of rashes. A lot of it is STD testing, and you'll have pelvic exams a lot because you'll have a woman coming in with yeast complaints or BV or all this type of stuff, and you do pelvic exams for them. There's a lot of strep testing, ear infections, and a lot of x-rays. A lot of patients come in and want an x-ray. They're playing soccer or finger jammed or all different stories, and they come in for the x-ray because they know that they get an x-ray that day. And lacerations. So if someone has a cut, dog bite, etc. So there are different ways you could close lacerations. You have a video on that, your sutures, your staples. Some of them you don't close, and some of them just steri strips, glue. It really depends on the laceration. But a lot of patients are basically coming in for that. Coming in for viruses, pelvic exams, STD testing. So the main thing in the urgent care, I would say, is really to know when to refer. And there's certain things you can't miss in urgent care. So even if everyone comes in with the virus, you can't miss the one person that's been coughing because of lung cancer, for instance. You know what I'm saying? So you can't just be like, bye, COVID testing or whatever. You really have to know. You really have to listen. You really have to listen to their history. Is this been happening for a while? Is this, were they past smokers? Like stuff like that. You really have to get a good history, listen to them, and not just come in thinking you know what they have, and they don't know what to talk about. Listen to them. They usually know their body. Listen, if they're saying it's not normal, it's not normal. And, always give them proper precautions. Say if this doesn't resolve, if this gets worse, or if these symptoms happen, be seen, and certain symptoms warrant ED right away. Lethargy, confusion, shortness of breath, chest pain, straight to the ED. So you got to tell them these stuff so that they know what to look out for, because certain stuff could progress. And I also like to tell my patients that I know this is urgent care, and a lot of patients like to use urgent cares as primary cares, but a lot of stuff are missed that way. So I really like to tell them that they really should have a primary care. I explain to them why, and they understand, and they get it. So that's pretty much it. I would just say it's really all about, the regular stuff we do, knowing how to suture, knowing how to clean hairs, knowing how to, read x-rays, knowing how to read EKGs, etc. But it's also all about knowing the red flags not to miss and when to send to a higher level. So yeah, it's pretty much a day in the life of an urgent care nurse practitioner. If you have any questions, ask below, and like and subscribe. Bye.